Okay, so again, for those that are tuning in, I'm Christina Steyer with the Iowa AAP, and we're learning about CCMV and how we can reduce the risk of infection. We will be joined today by several wonderful speakers and panelists that I will get to in a moment here. I want to briefly mention that for the live event, there is continuing education credit provided, and you will receive your credit within 6 weeks of today's date or sooner. And there will be an evaluation link that will be shared at the tail end of the presentation. And I will also share in a follow-up email that will showcase some of the resources and stuff that we talk about in today's webinar alongside that evaluation. Very helpful for us for planning for future webinars. This is a brief disclosure that this webinar is supported and funded by the CDC and American Academy of Pediatrics. And I also want to give a huge shout out to all the partners that have helped us with this grant project that has led to this webinar that we're putting on today. That includes Iowa HHS and their SetNet team. I see a few of the folks on the webinar here today, so thank you so much for joining us. The National CMV Foundation, the Iowa Academy of Family Physicians, and the American College of Obstetrics and Gynecology. I'm sure I'm missing several others, so if I did, please pop it in the chat or feel free to email me and let me know that I should not have forgotten your amazing organization because we could not have put this on without you. That is all that I have to put forth. So I'm going to stop sharing my screen and I'm going to hand it over to Dr. Joel Waddell, who is a pediatrician and infectious disease specialist, and is going to give us the groundwork or foundation of CCMV to kind of start the conversation before we head into the panel. So Dr. Waddell, whenever you're ready to share your screen and we can get started.
Okay, there's at least a 50% chance I'm going to do this wrong at first. So let me...
Perfect.
Okay, you can see my slides?
Yes.
Oh, perfect. Okay. All right. Well, yes. Thank you for letting me be a part of the panel. I really appreciate it. This is such an important topic, and I appreciate everyone taking time to come and talk and dialogue about this. So, but without further ado, I am one of the pediatric infectious diseases doctors here at Blaine Children's Hospital, and there's two of us in Central Iowa. So not a ton, but we can get going, but I have no financial disclosures. So just a quick outline. So we're going to go through the various clinical manifestations of congenital CMV, which there's quite a bit. And I thought it made more sense that as I go through each clinical manifestation, I talk about what is the treatment, instead of trying to go back later and try, well, what did you say about that manifestation? So we'll do manifestations and treatment as we go. We'll kind of give broad prognosis statements here. We'll talk about transmission. So as we're thinking about education and how to talk to families, how to talk to other providers, understanding the transmission of CMV is big. We will that'll dovetail perfectly into hopefully the virology, so understanding the virus itself and the epidemiology. And then how do you make the diagnosis? What are some known preventative measures, and what are some prevention measures that are in the pike that might come down a little later? And then how do you follow up a kid who's been diagnosed with congenital CMV? So clinical manifestations, as I kind of alluded to, there's a lot. There's a wide array of manifestations. And so the first key thing, and I want you to understand, is the vast majority of congenital cytomegalovirus infections, the vast majority have zero symptoms. So 9 out of 10 congenital CMV infections are asymptomatic at birth. There can be mildly symptomatic that we'll talk about. There's another group of moderately to severely symptomatic patients. And then there's this interesting section that's labeled as asymptomatic with isolated sensorineural hearing loss. It's a topic of debate we're going to get into a little bit. And just so you know, there's numerous guidelines from numerous countries about congenital CMV. There are European guidelines, international guidelines. There's the American Academy of Pediatrics Red Book. That's kind of our one of our biggest infectious diseases books in kids. So the terms slightly differ. Most of my terminology is consistent with the AAP, since this is an AAP talk. So let's talk about mildly symptomatic. So the definition here is you have one or two clinically insignificant findings. So a child is born, they have petechiae. Maybe they have mild, underline mild there, hepatomegaly. Their liver is a little big. Thrombocytopenia, maybe some mildly elevated LFTs, hyperbiliary that's conjugated, or isolated symmetric small for gestational age, or IUGR. So if you have a couple of these and they resolve by 2 weeks, other than the SGA, then you call that mild and pretty much self-resolving. And so in general, most countries in the AP will say you don't need treatment for these cases. They can be on a case-by-case basis. So it leaves a little bit of open door in terms of treatment. One thing I do want to highlight here is that a lot of babies, I mean, the birthing process is traumatic. A lot of babies are born and have petechiae. Most of those children are not screened for CMV, at least in the state of Iowa. Sometimes I get a call on this. Hey, I got this baby with petechiae. What do you think? I always recommend testing for CMV. It's easy to test for, and if you find it, there are things that can be done to monitor for complications, etc. So now we're moving to children who are more severely affected. So these are kids who, those things I just mentioned, thrombocytopenia, big liver, it's still the same things, but they last more than 2 weeks. Then you say, okay, this child is not getting over their disease or the symptoms from CMV on their own. So let's put that into the moderate or severe disease. Or if they have numerous mild manifestations. So if it's not just one or two, but it's a lot, even in those cases of less than 2 weeks, we'd say that's moderate to severe. Of course, any life-threatening disease or any single organ, a severe single organ or multi-organ disease. So for example, a lot of babies might be born and have, ALT, liver function test in the low 100s. Okay, I put that in the mild. If a baby's born and they have liver function test in the thousands, that's not mild. I don't need to know anything else that's severe CMV. So if you Google, congenital CMV, or what you see in nursing school, med school, is that blueberry muffin rash. It's non-specific to CMV, but it's a of severe cases you'll see that, and it's intradermal hematopoiesis. That usually doesn't come by itself, but if you see that, you definitely need to be testing for CMV. And then any central nervous system involvement, bingo, you have severe disease, don't need to know anything else. So let's talk, what does that mean, CNS disease? So if a child is born with microcephaly and they have CMV, that's severe disease. If they had a lumbar puncture performed, a spinal tap, if their CSF indices are high, so they have a lot of white blood cells, or CMV positive PCR on the CSF, that's CNS disease. I should take a quick note and say it's not a routine recommendation where you have to do an LP on babies who you think might have CMV, but if you're doing it for other reasons, they had seizures, etc., you can find that. And then another thing, just before I forget, on this note is having a negative CMV PCR from the CSF does not exclude congenital CMV. It even does not exclude CNS disease, because there can be certainly negative results there, but they have CNS disease. If you do an exam and their neuro exam's abnormal, that's CNS disease, or if they have seizures. If they have an eye exam and you see chorioretinitis or optic atrophy, CNS disease, so chorioretinitis is one of the classic ones that you'll hear about. Or any, not any abnormal neuroimaging, abnormal neurological imaging consistent with CMV. So if you get the classic periventricular calcifications, that's kind of an easy one. There can be what's more vaguely described as periventricular echogenicity. So if you see something that has an abnormal uptake in the periventricular area, and you know they have CMV, you call that disease. If they have large ventricles, white matter changes, or if they have malformations or hypoplasia. So some babies, when they're born with congenital CMV, they're so affected that their brains just physically do not grow to a normal size. And the other is, as you know, going back to embryology, as the brain develops, it has to migrate in certain sequence, and if there are migration abnormalities, that's a big one. And that can happen if the CMV infection happens early in pregnancy, where migration doesn't happen like it's supposed to. So if you look at this image, these images here, you can see a couple of things, and you can see what I was just alluding to there at the end. So the fetal brain arrested in development. So you have oversimplification of the gyral system, and so you're supposed to see all those small indentations throughout the brain, those little grooves. You're not seeing that. This is a fairly smooth brain, which is not good. You're seeing those periventricular calcifications. So those the white areas that you see on the CT, and then prominent ventricles. So the ventricles are not supposed to be that big, and that indicates that the brain matter itself, the cerebral volume, is decreased. And on this side, you can see that it doesn't have to affect each side of the brain equally. So in this picture, the right hemisphere is smaller, and then if you look at the child's right, so your left, if you look at the right side, you see how smooth that is. Again, that's not a good thing. And if you compare it to the left side, you can see that the more gyral indentations that you would expect. This is the blueberry muffin rash. So you'll notice a couple of things. You'll notice there's petechiae, but then there's even some larger areas that are more like purpura, and then the baby is quite jaundiced. And then this can show you just how affected a child's head and brain development can be from congenital CMV, where they have a significant microcephaly. So back in the day, like 2014, 2015, Zika was everywhere in the news because it caused microcephaly. And I remember thinking then, like, that's great. We should talk about congenital Zika, but let's talk about congenital CMV, which is so much more common throughout the world. So treatment for moderate to severe disease, pretty much everybody agrees you provide antiviral therapy for these babies. So back in the day, early 2000s, we used to give the children 6 weeks of IV ganciclovir. So that's active directly against the virus. But there was a sentinel study done by David Kimberlin, I think in like 2008 or 2009, where he did a comparative study and found that if you give the children the oral form of the medication, valganciclovir, for 6 months, they have improved hearing and they have improved developmental outcomes at 2 years of age, which was huge. And this was one of those paradigm shifts where it changed standard of care. If a baby's in the NICU and they cannot absorb oral valganciclovir, you can use GAN while you're waiting. And currently, the AAP will say you can provide this antiviral therapy if it's given within the first 13 weeks of life. And the reason is studies showing that if you initiate after this, it does not provide any benefit. This is actually a fairly recent change because early data that was smaller studies and didn't follow kids as long showed that you had to start treatment within the first 4 weeks of life. So if you've ever learned that, this is a change that we're seeing. All right. So asymptomatic, I shouldn't call it asymptomatic, but isolated hearing loss. So CMV is the leading non-genetic cause of hearing loss in the US in children. And it happens in about 50% of kids who have other symptoms of CMV disease at birth. That's a lot. I mean, that is a lot. That's a big percentage. But one thing I want you to notice is the next bullet point. 15% of asymptomatic infections go on to develop hearing loss. So if you kind of think back, what percentage of kids are born without any symptoms? 90%. As you're thinking about that, that's 90% of kids. We probably don't even know they have CMV, and as an individual risk, they have a 15% chance of having hearing loss in the next couple of years of life. Another key thing is almost half, not quite half, who eventually have hearing loss have normal hearing screens at birth. Normal hearing, if they happen to get a hearing screen the first month of life, all that's normal. So having a normal hearing screen at birth does not exclude the fact that you're going to develop CMV associated hearing loss later. And it's variable. So some kids have mild hearing loss. Some kids have profound hearing loss and they need cochlear implants. It can be one ear, it can be both ears. Like I said, it can be at birth, it can be delayed. So this is not a one size fits all, and that needs to be really highlighted. So, do you treat? I'm going to bear with me. I'm going to go with you through the history over the last just few years. So there's different guidelines. Since 2017, the International Consensus Guidelines, this is the one the U.S. has traditionally followed, said don't treat. The Europeans, the same year, they couldn't all agree on that huge form, but most of them said you should treat. Did they tell you how long to treat? They did not. A study the next year in Israel said we gave these babies 6 months of Valgan and had improvement in hearing in most ears. That's a lot. So this was a big study, right? And this it mirrors what David Kimberlin did in 2009 when he found symptomatic kids at birth had better hearing at 2 years. So the red book comes out every 3 years. So the last red book said, don't treat. I would tell you I was treating. A study in the Netherlands in 2024 said if you gave 6 weeks of oral Valgan versus nothing, you had improved hearing. The current European guidelines don't say, most of us agree, now they recommend treatment. They don't tell you how long to treat. The new Red Book says Valgan may be offered for 6 weeks if started within the first 13 weeks of life. So what this tells you is we can't agree across countries. We can't even agree in countries. But in general, most people are now moving to offering some treatment. And I will tell you anecdotally, I treat with shared decision making with the families. And I have seen the similar results anecdotally to what has been seen in Israel, what has been seen in the Netherlands. I've seen improvement of hearing and not in every child, but I've seen real world results. So what's the downside of treating? So a lot of kids are going to get neutropenia. So if it drops below 500, we just pause it for a bit and it comes up in almost every case. Most kids don't go below 500. You might get a small bump in their LFTs. It's a theoretical risk. You can give them an AKI. I've never personally ever seen that. And then some will argue, what about side effects you've never seen? We haven't studied for decades and decades. And I'll say, well, I know I have a risk of hearing loss and they're theoretical risks. So I think treatment in those cases is worthwhile. But it's not a small endeavor. You got to check the baby's labs once a week for the first 6 weeks. I don't know about your kids. My kids cried because they must have hated their father or something, but poking them once a week would have been very, very challenging. So it's not a small thing. So what's the real world? What do you do if a child that you're following fails their hearing screen at birth? So there's a law in Iowa that mandates CMV testing if they fail the hearing screen. So if they fail a hearing screen at birth, repeat the hearing screen. We all know if you do a first hearing screen, it could be a false positive. So if they pass the second hearing screen, you're done, move on with life. If they still fail it, then you go and you do a saliva PCR for CMV. I say saliva, just that's very easy to obtain. You don't have to wait for this baby who pees once every 24 hours in the first day of life to pee for you. If that is positive, then you want to look. Make sure you do a thorough exam. Do they have any signs or symptoms of CMV? And then you want to confirm the positive saliva PCR with a urine PCR. And I say that because CMV is excreted in breast milk. And if a baby got breast milk, then it is certainly possible you got a false positive. And a urine PCR has a very high sensitivity and almost a no false positives. So if the urine PCR is positive, refer them to ID, and then the other workup for congenital CMV would be all these things listed here. You're going to do some labs. Usually we'll do this in ID clinic, but just so you know what we're doing. Another would be a head ultrasound. So you don't want to do this anywhere. So you will need to do this at a place who's has pediatric radiologists who are comfortable interpreting it. They need to follow with audiology because, like I said, if you don't, then you're going to miss about 40% of kids who are going to get hearing loss, and then an eye exam by an ophthalmologist. So mortality is fairly low. I mean, that 10% is pretty high. I don't think that's not what I'm seeing in the real world. But you can have developmental delays. Congenital CMV is a known cause of autism. So autism, there's a lot. It's a very a complex diagnosis. It's genetic and environmental, but we know that having congenital CMV increases your risk of autism, cerebral palsy. These are uncommon developmental changes in children who have asymptomatic CMV disease. So transmission. So the big two, if you don't remember anything else from this slide, remember urine and saliva. So most CMV is transmitted through urine and saliva. It can be in numerous other secretions, vaginal secretions, semen, milk, blood, tears. But a key point here is that young children have higher rates of CMV excretion, especially in their urine and saliva in the first 2 years of life. So that's a big risk factor, being around kids of this age. And if they're in childcare, it's an even higher risk factor. So vertical transmission does occur transplacentally. And about a third of kids will get infected if mom has a primary infection during pregnancy. But here's something that to be aware of. There can be transmission of CMV to the baby, even if the pregnant patient has had CMV antibodies. So how does that happen? So one is there could be a clinical reactivation of CMV, where the mom maybe is not getting symptoms, but it could go to the child. Mom could get infected with a new viral strain, and then most infections in the U.S. For congenital CMV happen in pregnant women who don't have a primary infection. They've had CMV in the past. You can get severe disease, long-term sequelae, even if there's been CMV in the past in the pregnant person, but there's a higher risk of that if there's a primary infection. There's no seasonality of CMV, so it's in the herpes virus family. The same thing as like EBV, HSV, VZV, and you have lifelong infection. You can't get rid of it. It's typically latent unless you have significant immunosuppression. You're on chemotherapy, a bone marrow transplant, etc. So when you just look at the seroprevalence in general, it's 50%-ish, but I think it's more important to break it down. So if you look at seroprevalence in women of childbearing age, it differs dramatically by race and ethnicity. So white females have a pretty low seroconversion here under 30 years of age, only about a third, and only about half have had it by the time they hit 40. And compare that to Black females, it's dramatically higher, where most have had it, and then 95% in the 40s. And then if you look at Mexican American females, it's even higher in the younger age groups. So now, what about how common is congenital CMV? So in general, 1 in 200 births. I mean, that's a lot. But again, let's break it down. So 1 in every 100 babies born to African American females will have congenital CMV. I mean, that's a lot. Pretty similar numbers for Native Americans and Native Alaskans. If you look at those born to white females, it's only 1 in 250. So and Hispanics are about the same. So when you're thinking about risk factors, when you're doing your communication, young maternal age is one of the bigger risk factors, just because they might not have been exposed to it in the past. If you work in a childcare facility, you're at high risk, or if you have maternal HIV, those are all risk factors. If you think these numbers are high, in other countries, it's 1 in 30 children are born with CMV. So I just want you to look at Iowa here, right? That's the only state that matters. Okay, so when you look at Iowa, the lighter blue, it means the fewer cases of congenital CMV. And it's not really changing throughout the years. We have a fairly low rate compared to other states. That's one, as these maps come out, more states are doing universal screening. We are not. So you might see surrounding states go up even further while we stay stagnant. That's not that our rates are staying the same and the rates are going up. It's maybe a difference in testing. Another thing is this is pretty consistent. So if you talk to the hematologists, those and the blood bank docs and pathologists, we have a pretty high access to CMV negative blood for blood donations. That's just an interesting epi standpoint. We're getting to the end, but antibodies aren't really helpful in diagnosing. You have to do a CMV PCR like I alluded to earlier, and then some centers can do a dried blood spot. So everyone should be kind of educated on these preventive measures, and that's what's been shown to help out. So basically saying, hey, don't share food, drinks, utensils that have other young children have used. Anything a child has put in their mouth. Try not to kiss when the saliva of a child, and other things like that. Just these risk reduction behaviors have been quite successful. So some have looked at, do we give an antiviral medicine? So nobody has really looked at giving valganciclovir. Some have used valacyclovir, which we know treats HSV. An Israel study showed it actually worked, decreased vertical transmission to the babies. Meta-analysis showed the same thing. And so the Europeans have said, we're doing it. We're going to test every mom for CMV in the first trimester of pregnancy. If they're antibody positive, we move on with life. If they're negative, we're going to continue to test. And if they seroconvert, we're going to treat the mom. This is not currently recommended in the US. They're pretty much waiting for larger studies. And then there's a couple vaccines in the works, but we're years away for that. Just remember that these neonates need audiology follow-up, eye follow-up, and then developmental screens. So I'll stop there because I think we have a lot more to go through.
Thank you so much, Dr. Waddell. Are there any immediate questions following this fantastic overlay of what we will discuss further with our panelists? Okay, hearing none. I'm going to go ahead and move us over to the panel. So let me quickly add folks. Okay, apologies. So I will briefly introduce, but I'm going to have our panelists give us more of an in-depth understanding of their role when talking about CCNV. So we just heard from Dr. Waddell, who, as I said, is a pediatrician and infectious disease specialist. We have Dr. Courtney, who is a family medicine physician, from Mason City, and then Amanda Devereaux, who is a nurse by training, has worked with the National CMV Foundation, and has her own lived experience, which I will give her time to explain in more detail. I'm going to ask that we start with the physicians to introduce yourselves, your length of time in practice, and your experiencing and assessing and making referrals for infants born with CCMV. And Dr. Waddell, since you spoke first, I'm going to have you start us off.
Yeah, I've been at Blank for 6 years now as an attending, and yeah, I get frequent referrals from pediatricians, family med providers, newborn nurseries for congenital CMV, kind of throughout the central Iowa area. Feel pretty lucky to be involved in these families' lives.
I'm Patrick Courtney. I'm the program director at the Family Medicine Residency up here in Mason City. And I think one of the big reasons I was probably asked to join is, I will kind of hit on both the prenatal care side of stuff, and then also on the what goes on with, third trimester and delivery and in the what happens in the nursery. So both here and when I was out practicing in the cornfields of Carroll County before I joined the faculty here, I've been kind of nice to be able to collaborate with pediatricians on this side of stuff. So have definitely done workups and referral for CMV before, and I've always worked in places where usually that gets referred to the big city.
Fantastic. Thank you so much. And thank you for being here. Amanda, please give us an overview of your experience.
Okay. I'm going to share my slides here. I just have a few. Okay. Hi, everyone. I'm Amanda Devereaux. As Christina said, I'm a nurse, and I've actually been a maternal child health nurse for 11 years. So that's always been my focus. I have worked as a nurse home visitor for pregnant patients for pretty much that whole time, except I did work as the program director for National CMV Foundation for 5 years. And so I've met a lot of families with CMV, a lot of experience working with them. And I have my own story to share. So this is just a few slides about my daughter, Pippa. So she was born in 2015 while I was a maternal child health nurse, and we never talked about CMV. And so this is us shortly before she was born, but we had a planned second pregnancy and we had preconception counseling, and we never heard the term CMV, even though I had a child in daycare. And so I was at higher risk. She was due in November of that year. And so we started at the general OB. Actually, we started at a fertility clinic and then moved to the OB clinic. And then when we had our 20-week ultrasound, there was a slight variation with her cerebellum. It was measuring 3 weeks behind. And so they referred us over to the perinatologist. And so we went over there. And I remember him saying, there's 3 things this could be. And he said it could be something genetic, it could be a normal variation, it could be CMV. I didn't even pay attention to CMV when he said that. But we waited to get those test results back, and it did show congenital CMV or CMV in the amniotic fluid. We were not given a ton of options at that time. We were told we could terminate the pregnancy or we could do nothing. And we weren't super happy with those choices. So we did, again, this was 10 years ago. So we went and had a consultation at the University of Minnesota. There's world-renowned CMV researchers up there. And we were given the opportunity to participate in experimental treatment. And so no longer are people really doing this, but we did receive hyperimmune globulin 4 doses during the pregnancy. It was the only really option available, and we really wanted to try something. So at that time, our insurance did cover us to get those treatments. My daughter Pippa was born in October. She was actually born at 34 weeks in Minnesota. It was kind of a surprise. She stopped moving. So this is your plug for Count the Kicks as well, because she stopped moving and they did the test and they said we should just get her out. So we did. I will say, just to note, she looked completely typical at birth. There was no rash, there was no small head size, there was no hearing loss. She passed the hearing screening, but she had plenty of symptoms. CMV was in all of her body fluids. She had intracranial calcifications and thrombocytopenia. That's what they could see right there initially at the hospital when they did further testing. She was in the NICU for 3 weeks, but that was just for feeding and growing. And she did receive 6 months of the oral antiviral. These are old pictures. I've got new ones scattered through here, but currently one of her biggest diagnoses is polymicrogyria. We found out about that about 6 months when she started not meeting a lot of her milestones. We had an MRI. She's got seizures. She has an intellectual disability. She's non-speaking. She uses an AAC device. She has mild to moderate hearing loss and lots of feeding issues. She's 70 to 80% tube fed. But she's super happy. She loves numbers and letters. She loves watching Daniel Tiger, going swimming, going bowling. She loves going to school. So she's a really happy 9-year-old girl. Huge impact on our family. I'm not going to go into that too much at this point, but every single aspect of our lives is different than it would have been. We don't even live in the same place that we would have lived had this not happened. So Dr. Waddell talked about our law. We contacted our legislators when I was still pregnant with Pippa. It is a rare thing to find out during pregnancy. That doesn't usually happen, but it did happen for us. So we started working on legislation. So the law was passed in 2017. It does require prenatal education. So if OB providers are not giving a specific pamphlet to their pregnant patients, they're not following the law. And then, as Dr. Waddell said, it does require test for CMV if the newborn fails their hearing screening. And I like to share this quote from Dr. Bill Rawlinson from Australia. He's an infectious disease specialist, and he just always, when he talks to these moms, he says, it's really patronizing that people aren't being told about this. The families I work with, they wanted to know, and they didn't know about it until this happened to them. And so that's kind of the most common thing that I hear from families. And that is all. I'm always willing to connect with families. So I know there's a lot of people on the call who work with families with this diagnosis. My personal email's on there. I love talking to families about this. I didn't know anybody when this happened to me in Iowa. So I'm so happy to connect with families if that's ever needed.
Thank you so much, Amanda, for sharing your story and really highlighting why we're talking about this today, because it impacts so many families in the state and around the US. So thank you for that, for being vulnerable and sharing that. Moving into the panelist questions, I have a couple that I prepared, and I want to leave time for folks to ask questions as well. I'm going to start with something that Dr. Waddell kind of alluded to during his presentation. I'm curious, and I'm sure some of our participants are as well. Where do you see the biggest gaps or challenges when it comes to research, clinical practice, or public awareness when it comes to reducing CMV risk?
Yeah, thank you, Amanda, as well, for sharing that. It gives a personal story to what's going on. Yeah, I think that what Amanda hit on was one of the big key issues, is that I still have most families say, I've never heard of CMV. I've heard of Zika. I live in Iowa, and I've heard of Zika. I've never heard of CMV. People who are in healthcare haven't heard of it. And I think that one of the biggest gaps that we don't need a research, we don't need huge funding, is perinatal education. That if you're around young children who are excreting higher viral loads in the urine and saliva, not that it's going to prevent every case, but there has been research. It statistically decreases your risk of having a child with congenital CMV if you are given that education. And so doing the bare minimum pamphlet, I think, is good, but I think making it a standard of care, of talking to families about it, making sure they understand, and they can do the teach back method of tell me how you're going to decrease your child's risk. And then starting there and saying also, this is not perfect. And if whatever happens, it's not the parent's fault, and I try to make sure I say that out loud and verbalize it to the families. So that's the not easy one, but that's the first one that we could get started on right away. Some gaps in research, and I'll definitely leave it to people. So I'm sorry, I get long-winded. One is that I think could be really helpful is a vaccine. We're ways away from that. But another could be seeing what I think in Australia, I think they did the first studies in Israel where they give moms valacyclovir. Excuse me. So that has a known good safety profile in pregnant women and fetuses, that it decreases the chances of when a primary CMV infection happens of it going to the child. So we need big studies that show that that's true, so that the FDA will adopt it, and so our OBGYNs and family med docs feel comfortable doing it, because I don't blame them for not doing it when it's one study of 100 people and the FDA doesn't recognize it. I mean, I could go on and on, but I will stop to give other people. But those are two big areas that I think could be actionable: valacyclovir and education. That we can maybe make some headway on this.
Yeah, I guess I would say that the big obstruction I see within kind of research is going from being able to say, hey, we've found something, to be able to say, hey, we can actually do something about it. And that old adage that you shouldn't screen for something if you can't treat it. I think there are okay screenings and there are okay treatments for CMV. And really trying to get through large, randomized, good studied stuff in pregnant people is always a big challenge to do. And so, I think we've gotten, or we are getting more to the point of saying, hey, this is actually an issue. But then getting the science to catch up with it and say, who do we screen, who do we treat, and getting all of that guidelines and data into place has been slow for this disease.
Thank you for that. I do see a question in the chat, and I will get to that one in just a second. I want to turn it over to Amanda and ask, what message would you like healthcare providers to hear directly from parents about CMV education, as Dr. Waddell and Dr. Courtney addressed it?
Yeah. Well, I think first of all, I would just say that there has been research that parents want this information. So you don't have to withhold this to try to make people feel better. It's okay to say, we don't have the best answers about CMV. It's very complex. There's not a silver bullet that's going to solve this, right? It's okay to say, I'm the doctor, but I don't know all the answers, and we don't have all the answers. Science doesn't have all the answers yet. So I think that's one thing. The second thing I would just say, we hear from families all the time that the doctors they're working with are not familiar with this. So, and sometimes they're not getting the best information. So I guess our families feel like it'd be great if physicians could kind of refresh themselves, because they may be relying on old knowledge or relying on the fact that they don't think they've ever seen this before. They say, I've delivered babies for 25 years and I've never had a baby with CMV. And it's like, well, yeah, you did. But the symptoms were so subtle, or they were one of the asymptomatic ones. And by the time that those symptoms show up, it's too late to go back and say CMV was the cause. So I actually had my family physician doctor. I was having a little mental health issues dealing with all of this when my daughter was born. And I told her about it. And the first thing she said to me is, oh, that's so rare. And I said, well, first of all, it's not really that rare. You wouldn't say that to somebody who delivered a baby with Down syndrome. And, it's second of all, that's not helpful at all. Like, even if it was really, really rare, that didn't matter to me because it happened to me. So I think that's another thing that our families would like to see, is just people getting really up to date and make sure that they're relying on the most recent information.
Absolutely. Thank you so much for adding that. A question in the chat, and now we have two. All right, well, starting with a question directed to Dr. Waddell, but I will open up to Dr. Courtney as well. What are your thoughts about universal screening versus targeted screening for CMV?
Yeah, so universal screen, for those who don't know, there are some states who have initiated universal screening for babies, and what that means is on every single child born, doing a CMV test on them, regardless of their symptoms, just like a newborn screen. There's a little disagreement on if you do it on dry blood spot or saliva or what you do, but some have initiated. Minnesota, I think, was the first, and this is an area of huge debate. I'll tell you what other people say on both sides, and I'll tell you my opinion. But so on the one side, you'll have some people say you're going to induce a lot of maternal and paternal anxiety with no actions that can be taken. And 80-90% of the time of a positive result, there's going to be nothing that comes out of it. And you have nothing to offer, no medicine to offer an asymptomatic kid. So inducing anxiety to parents of a newborn is not a small thing. So I kind of get that. On the flip side, after Minnesota initiated their screenings, they have published a paper talking about this. And when you do it, it has resulted in improved outcomes, neurodevelopmental and audiological outcomes for those children, because you can get them into speech therapy earlier, occupational therapy earlier, et cetera, et cetera. And so there is significant potential for benefit. So if you had a different ID doc on, they might give you a different answer. My answer is I would personally be in favor of universal screening. One, that would immediately raise awareness. Two, I have found the same thing anecdotally, as Amanda has alluded to, is that I don't think that people would be mad that you have a diagnosis. I think they would be, in general, happy to have as much healthcare information as they can about their children and the health of their children. And I think it was a Minnesota study that showed you don't induce anxiety by introducing this. So it's actually been studied. So again, I might even be in the minority here, and that's okay. But that's the general landscape of universal screening.
I guess I would probably take the slow and steady approach instead and say, like, it needs to be study it from step 1 to 2 to 3. Like, we know that we can pick up asymptomatic infections, but then what do you do with them? Do you give them antivirals? Do you do serial ultrasounds of their head? Like, what do you do with the positive CMV test in somebody who's got no symptoms and a normal hearing screen that you wouldn't do for a normal kid?
Yeah, and we do need more research on that, and that's what I'm forgetting his name now, the guy in Minnesota, who's done all the research, and so he kind of outlined what you would do, and it's not robust yet, but it was basically you get them into therapies earlier, and at least in his study, he found that it improved developmental outcomes. But yeah, we certainly need more. We need more information. I think New York and Connecticut are now doing it. So that's the first key, kind of like you're getting at, is saying, is it reproducible? Or is it a fluke in Minnesota? Is it if we start to see other states are getting like those interventions early and getting improved outcomes, then maybe there's more evidence that would lean behind doing it. But yeah, we definitely need more data.
Fantastic. Thank you both. I'm going to move us into another clinician question. So what barriers do clinicians face in discussing CMV prevention strategies with patients?
I'll go again. So I think kind of the big one with um, prenatal education and that side of stuff is trying to find the right balance and trying to be able to, counsel people to be able to avoid exposure without making them feel like they need to wrap themselves in a bubble and like, hey, I can't kiss my toddler anymore, and um, I need to be afraid of my toddler, um, type of that side of stuff. And then also just within the like, hey, I'm getting a primary infection. Like, do I have fatigue because I now have mono from CMV? Or am I tired because my placenta is releasing all sorts of hormones and it's my first trimester and I'm tired? And, trying to fit all of that education and then the questions from that all into a prenatal visit when there's, not enough people doing prenatal care in Iowa is, I think, what I would say is the first barrier. And so having that in-person discussion and really being able to deliver it with that relationship and body language and tone of voice instead of just here's your pamphlet, read it, and please don't throw it in the trash is tricky. And do I talk about and in as I'm, doing my time, do I talk about, general diet? Do I talk about don't eat swordfish to get mercury? Do I talk about CMV? Do I talk about, you know, prenatal weight gain? Do I talk about all that stuff? And where do I budget my time?
Dr. Waddell, your thoughts?
I'm not involved on that side up front, like directly. I mean, with women, unless they have a diagnosis of CMV, and then I'll see them. But yeah, I would imagine that. I mean, there's so much that's even in almost every visit is being jammed in over and over, and so I think time constraint is one of the big things, especially as we have, like Patrick's saying, fewer and fewer providers providing OBGYN care, especially in rural Iowa. I mean, that's a big one. I think it's all about time. And so, getting out, talking and things like this, um, more broad general education to where the families bring the questions to you. Not that that's the only thing, but I think that can be an important component because we've all probably seen an ad about smoking in pregnancy or alcohol in pregnancy. Um, but yeah, I think there's a way to educate the general public as well as maybe in person. But yeah, time is the biggest constraint.
Yeah. And I guess on the other side of, well, not the other side of that, but I mean, does all of this education need to be done by the providers? We look at, diabetes, and diabetes has diabetic educators out there, and, you know, kind of the traditional role of midwives has been as a parallel track to care by a physician, and that's kind of stunted or precluded the normal like shared care that happens in a lot of other diseases between providers and nurses for that education side that nurses do really well.
Fantastic point. I will turn to Amanda. Are there other areas that could either address the barriers that we've already discussed or additional collaborations that we can have as those that work in the public health field here in the healthcare system to raise awareness and talk about reducing risk?
Yeah, I think nurses are a perfect fit for CMV education. We do nurse home visitations, so we're seeing the pregnant folks in their homes. That's a great spot for us to do it. We have more time, so we provide that education to all of our patients. I will say I don't get a lot. I can't think of a time when I've had someone feel panicked after talking through it with them, because I do have the time to sit down and talk to them about it. I think the other thing just to kind of think about too is like, can we prioritize what we're spending our time talking about? So if we're spending time talking about listeria, is that more likely than CMV during the pregnancy? No, it's not. Or toxoplasmosis or other things that we are spending that important time on. Can we kind of prioritize, the things that are more likely to happen? And CMV being one of those things.
Thank you. We do have a question in the chat. Is CCMV a reportable disease in Iowa?
I just Googled it and it is.
I think that was part of the legislation a few years ago, is that I could be wrong, but I think when that passed, that's what initiated to become a reportable disease, because there's that law in place that you have to have a hearing test.
I think it was tough because there was no reporting required with the law. And so I think some folks at IDPH, shout out to Kim Piper, I think worked on getting that added as a reportable condition.
Nice.
Yeah, CMV is a reportable condition in Iowa. And clinical laboratories are required to report the results of all CMV testing on Iowans. And then we parse it out through our surveillance program. We parse it out and we look at women of reproductive age and newborns or infants less than 42 days of age to determine some positive test rates.
Fantastic, thank you.
I just linked the HHS reportable diseases 3-page sheet in the chat.
Perfect. I will ensure to share that out with folks. I know we're running low on time. Are there additional questions from the audience that you're wanting answered? If not, I'll ask our panelists if there's any parting thoughts, any last minute pieces of advice you'd like to give to participants and those that are watching the recording.
I would start with saying that, if you've realized in this that, CCMV is maybe something that you need to think more about, go chat with your hospital committees and double check your EMR templates and make sure they're in there. That would be a good action item to just transition this knowledge into something that can help patients.
Yeah. And I would say if you're taking care of a newborn and you're like, should I test for CMV? Just test. It's so easy to test. And if it's positive, even if the kid's asymptomatic, you can get them into audiology. At bare minimum, if that's all you do, that's a big difference. If you're ever on the fence, just test. And the other I would say is, I've had numerous families come in with a 6-month-old, a 9-month-old and say, I'm looking back retrospectively and I've heard about this, CMV thing and people, I didn't get the dots connected until now. Is it CMV? And so one thing I would empower providers, families, nurses, everybody is that Kim probably knows this better than anybody, but the family can, just Google it. The family can request the dried blood spot, because that's the only way at that point we're going to make the diagnosis. And you can order a PCR to that. We send it to Arab. If it's positive, you have a diagnosis. If it's negative, it doesn't exclude CMV, but for some, just knowing that you can do something can be empowering.
I'll just add the CMV Public Health and Policy Conference is a great meeting to learn more about CMV. Lots of families, lots of world-renowned providers. That's happening next month, drivable to Minneapolis. So I put the link in the chat. So I would just encourage people to have a look at that.
And is that in person only?
Yes, in person only.
Okay, thank you. Okay, we are right at time, and I